One. Sir, we are live now. Now we can start the meeting. So please start.
Good evening and welcome to the SESI Journal Club. So while we wait for our president to join, I'll just give a brief overview of why we started this journal club. There are a couple of things which are the most important key points which I want to highlight. One is like any other subspecialty, the subspecialty of shoulder surgery has progressed over time, and we've had some really great landmark articles which have been published in the last 20 years, which have changed our view and our thought process about different aspects of shoulder. Now, the young colleagues, the juniors, they might not be aware of these papers. So it is important for us to know the history and learn and understand from the masters how their thought process worked when they perceived and thought about all this. So that was one main aim of this journal club. The second aim was to critically appraise the articles which are written. Nowadays, we have different types of articles being sent to us from all corners. We are being bombarded with articles, I should say, especially with the open access and technique articles which are being written. Now, younger colleagues can be sometimes carried away reading one article and thinking that probably that's the best treatment for that pathology, and they might try to implement it in their practice even before preliminary results come out. So we need to know the strengths and the weaknesses of the study. We need to evaluate that study well before applying the results of the study in our practice. So how to evaluate a paper, how to critically read a paper, that is very important. It is not only important to critically read a paper, but it is also important for us if we try to do some research to how to write a proper paper. Only when you start reading a paper critically, you will know, how to write your own paper. So the starting point for doing your own research and writing a paper is to read a paper and critically appraise it properly. So SESI, under the leadership of Dr. Deepthi Nandan, has come out with this journal club, and this is the first journal club. And we've got veteran scientists guiding us today. We got Dr. Vineet Abraham and Dr. Senthilvelavan. Both are accomplished, they have published a lot of good articles in peer-reviewed journals, and we got presenters who are also very well prepared for this event. So now I think our president has joined, so let's hear it from our president. Good evening, sir. Deepthi, sir.
Hi, Karthik. Good evening.
Good evening, sir.
Welcome, sir.
So, yeah, it's great to see that you got this working on a journal club. It's wonderful to see that we are having some journal clubs which are discussing the simple papers as well as some complicated ones.
Yeah.
And I think we should start with basics and then gradually work up is what I think.
Yeah.
Well, I think, Karthik, thank you very much for getting it together.
So we'll proceed, sir, with your
yes, please.
Yes.
Thank you.
So we were just talking about what is important as to how to read a paper is very important, so that we can write a paper properly. So we'll start without taking much time. We'll start with the first article. So the idea is to discuss two types of articles. One is the classic article, as we say. These are some of the classic articles which we feel that these are must-read articles for anybody who wants to dabble into shoulder. And then the second type of articles are the new articles which are coming out, to read them with a critical eye, whether to take the results, whether the study is done properly. Even if it is published in a peer-reviewed journal, there might be flaws, there might be inadequacies, which we are free to discuss and highlight. So let's start with the first paper. I invite Dr. Senthilvelavan and Dr. Giri for this.
Thank you very much for this initiative, Dr. Deepthi Nandan sir and Dr. Karthik. So it's been a real pleasure to kind of put things together. And first of all, the first paper is actually on the natural history of fatty infiltration and especially concentrating on infraspinatus in rotator cuff tears. So this paper is from France and it's from the veteran, Gilles Walsh. And, this actually was a significant paper in actually changing how we actually looked at fatty infiltration and what was its implication. So over to Dr. Giri, and I'll let him present, and then we will discuss further on the details on the critical analysis of the paper after his presentation.
Good evening, everyone. It's a privilege for me to be the first speaker in the inaugural SESI Journal Club. Thank you, Dr. Karthik sir and Dr. Deepthi Nandan sir and the whole SESI team and Dr. Senthilvelavan sir for this opportunity. So I have no relevant disclosures for this presentation. So as elaborated by Dr. Senthilvelavan sir, the topic for today's presentation is Natural History of Infraspinatus Fatty Infiltration in Rotator Cuff Tears, which was published in 2010 in the Journal of Shoulder and Elbow, which has a current impact factor of 2.9, publishing premier academic contents related to shoulder and elbow. This paper is from the legend, the Gilles Walsh group. As we all know, Dr. Walsh worked in Orthopaedic Center, Lyon, France, and this paper has been done in the particular center. He has published more than 483 articles to date with 5+ books and 35+ book chapters and about 35,000 citations, being one of the founding members of the European Shoulder and Elbow Society. So as practicing shoulder surgeons, whenever we see a cuff tear, we first look at, of course, the tear pattern and the amount of retraction. But the second thing we all search for is the amount of fatty infiltration or degeneration. As significant fatty atrophy changes our plan of care to salvage procedures like tendon transfers, superior capsular reconstruction, or even reverse shoulder arthroplasty. In this background, this paper seems to be very relevant, even though it has been published in 2010. It remains as one of the classics of published papers in shoulder and elbow surgery. So coming to the rationale of this study, so infraspinatus is one of the main depressors of humeral head, has some role in elevation and is a prime external rotator, and plays an important role in statically and dynamically centering the humeral head within the glenoid. Surgical delays in repair of rotator cuff tears has a potential of development and progression of fatty infiltration. So the objective of this paper is to study the natural evolution of fatty infiltration of infraspinatus and factors influencing its onset and worsening. Coming to the study characteristics, it's a study on the pathophysiology of fatty atrophy, trying to understand how it evolves over a period of time after rotator cuff tears. It is a retrospective study. It's a single center, single surgeon study. All these cases have been operated by Dr. Gilles Walsh himself, and it's one of the kind of study that was published in 2010. Analyzing its methodology in the form of PICO questionnaire. So the patients or the population under study is the patients with the rotator cuff tears whose exposure has been either rotator cuff repair or arthroscopic debridement or reverse shoulder arthroplasty. Patients who underwent repeat shoulder procedures are excluded from the study. There are no controls, and the outcome is the amount of fatty atrophy that is present either in CT arthrogram or the MRI. To put it in a simple words, over years, patients who have come to Dr. Walsh and have been operated were retrospectively reviewed based on the time of onset of the symptoms and the patient demographics. Their initial MRI and CT was studied to quantify the amount of fatty infiltration, and they tried to form a relationship between these factors. So no MRI post-surgery or no CT post-surgery is involved in the study. This is all preoperative data analysis. So they stage the rotator cuff tears based on the classical Gautier staging, either on CT or on MRI. So they used only axial cuts, which is, of course, contrary to what we do routinely using sagittal cuts. So stage 1, as we all know, is no fatty infiltration. Sorry, stage 0 is no fatty infiltration. Stage 1 is presence of fatty streaks. Stage 2 is less than 25% of fatty atrophy. Stage 3 is 50% of fatty atrophy, and stage 4 is more fat and less muscle. So this is the same classification on the MRI in the axial cuts. So how did they quantify the infraspinatus fatty infiltration? I would like to emphasize that they have only studied infraspinatus fatty atrophy in this study. So they have used two axial cuts to quantify infraspinatus fatty atrophy. So one is the high point or the coronoid tip, and the other is the low point or the infraglenoid rim of either CT or MRI. So when you see the left side, there are two cuts. One is at the coronoid tip, other is in the infraglenoid rim. So the first cut shows a stage 4 fatty atrophy, and the second cut shows a stage 2 fatty atrophy on a CT. So the mean of these two cuts were taken and is taken to be the final infraspinatus fatty atrophy of that particular patient. So the statistics were all appropriately used, and for the purpose of simplicity, they minimized the 5-stage of fatty atrophy into 3. One is either minimal or absent, which is grade 1 and 0, and the second one is medium, which is grade 2, and the third one is severe, which includes grade 3 and grade 4. In this study, they have described medium or grade 2 fatty atrophy as a point of no return, after which repair becomes really difficult. So for an optimal cuff repair, they have described the medium as a grade grade to be taken into account. Regarding the study epidemiology, the study period is vast from 1988 to 2005. 1,688 cases have been included in the study, of which 82 had only preoperative CT orthogram and only 18 had a preoperative MRI. 218 were partial thickness tears and 1,470 were full thickness tears. This table describes the full epidemiology. The points of interest are of the included rotator cuff tears, traumatic onset tears were 39.6%, whereas progressive onset or degenerative tears were 53.5%. And some tears, they couldn't determine the exact etiology, which was about 6.9%. When we look at the results, so the first relationship they studied was the thickness of the involved rotator cuffs that are torn and the number of tendons that are torn. So concluding this, they told that there is only minimal fatty atrophy whenever there is a partial thickness rotator cuff tear. And there is a gradual increase in amount of fatty atrophy as the number of tendons involved increases. If there is an isolated supraspinatus tear, there is less fatty atrophy of the infraspinatus when compared to either 2 tendons or 3 tendons involvement. And when you look closely, whenever the infraspinatus starts to get involved, the amount of fatty atrophy is also significantly increasing. That is, there is 30% severe fatty atrophy in cases where infraspinatus was involved when compared to the cases without infraspinatus involvement, which is only about 1.7%. The other way of looking at it is to highlight that even when infraspinatus is not involved and only either supraspinatus or supraspinatus where subscapularis is involved, there is still some amount of fatty atrophy in the infraspinatus. So even if infraspinatus is not involved, there is some amount of fatty atrophy in it. So this is a point to be highlighted. And the second result they try to describe is that there is a linear relationship between the duration of the tear and the development of fatty atrophy. To roughly describe this table, they have described that in case of traumatic tears, it takes 2 to 3 years to develop a medium fatty atrophy or the grade 2 fatty atrophy, whereas in progressive or degenerative tears, it takes about 4 to 5 years to develop a fatty atrophy. So the traumatic tears have a faster onset of fatty atrophy. That's what we can infer from this paper. And again, the other point they try to infer is that as the age progresses, the severity of fatty atrophy also increases. There is a linear relationship. We can see that severe fatty atrophy is more as the age progresses from this table. So what are the practice essentials that we can derive from this paper? The first practice essential is to measure fatty atrophy in axial plane also. This method of measurement potentially, avoids the bias whenever there is a significant retraction. When we try to calculate in the sagittal plane alone, we get misled. So looking at fatty atrophy in the axial plane is one take-home message, and the infraspinatus is involved even if there is no tear of infraspinatus. That is another carry-home message. Maybe we can take it like it's a more important rotator cuff muscle to look at. And there is a linear relationship between duration of symptoms, age, and the number of tendons involved with regards to development of fatty atrophy. And the other two research questions or questions to ponder are how early is early in case of rotator cuff repair. So according to this paper, till 2 to 3 years of traumatic tears, there is no development of significant amount of fatty atrophy or grade 2 fatty atrophy. So can we advise the patients that you can wait till 2 years? That's again a research question to look at. And the another question is, why do traumatic tears progress faster than the degenerative tears? These are two questions that we should ponder upon after reading this paper. However, coming to the limitations, there are a number of limitations. The study being published in 2010, and one of the kind of studies still, it's just a retrospective study. There is a large amount of recall bias, which can be attributed to delayed presentation of fatty atrophy in case of progressive or degenerative TS, where people will not be able to exactly recall when they started developing shoulder symptoms. It's of course a single center study which cannot be extrapolated to a larger population. So it's concentrated only in the French people. There is no periodic follow-up like in a prospective study at 3 months, 6 months to exactly put forward that fatty atrophy develops from this stage. There is no control arm. There are now studies showing that in old age, even without rotator cuff tear, there is significant amount of fatty atrophy developing in teres minor and infraspinatus. So there is no control arm. We can't take it as a level 1 study. And of course, they didn't describe about the supraspinatus fatty atrophy. This is like an incomplete data that is being presented here. And they didn't take into account the amount of retraction that is an important criteria. They didn't try to relate the amount of retraction on the fatty atrophy. And this study, 81% of people had CT arthrogram, whereas we almost all of us do only MRs for rotator cuff tear. So how to extrapolate a study finding from a CT arthrogram to MR is again a question and a limitation. And finally, this study quantifies that infraspinatus is involved in fatty atrophy even when there is no infraspinatus tear. But how did they exactly demarcate between infraspinatus and supraspinatus is again a question. So thank you for the opportunity.
So excellent, Dr. Giri. Thank you very much. It was very concise, clear. So to kind of like go ahead with the study itself. So, the relevance of this study, obviously the first question is it relevant? What do you think? There are a few things so obviously it's relevant. You actually put it up in the slides itself. And what does it add to the knowledge? Again, you've actually clearly demarcated that it adds more value in terms of like whether traumatic tears, degenerative tears, how it can actually vary, and it gives us new knowledge on to whether we can manage these patients conservatively and how long. When you advise the patients, can you actually wait till the point of return, or when you actually tell the patient in the OP you're seeing a 4 tendon tear, or you're actually seeing a partial tear, then, or if you're actually saying that it is associated with this particular age, then you can actually have some data in mind from the paper. So the study design, as you actually already mentioned, it's a retrospective study. That is one of the problems. But for such a large population group, and having a landmark study almost defining itself in terms of fatty infiltration. But what do you think the biases could be here? You mentioned a few of them, but
Yes, sir. So one potential bias can be the recall bias, since it's a retrospective study and large population has degenerative tear. So they might not exactly remember how severe their symptoms were and what is the point of onset of the symptoms. And again, it's a single-centered study based on a single surgeon. And there could be some observer bias as well.
So I think the one important point is the recall bias here, because the patients have all been contacted after, based on the data, and also the degenerative tests. Obviously, when did it start? Where was the shoulder pain? We can't say. And I think they have actually listed this as one of the limitations in the study as well, because a traumatic test is a precise point where actually they can say define from this point and then move forward. But obviously in a degenerative test that they cannot. And the methodology, they've actually had a robust methodology in which actually they followed up and they've clearly defined, multiple subgroups based on But there was one flaw, I think, I wouldn't say a flaw, but here actually, if you look at the table of the studies, they have actually reported the supraspinatus, subscapularis, infraspinatus, and also multiple tendons. But actually the paper, lists only the infraspinatus group because, that is one of the, they haven't reported on the supraspinatus at all, in fact, in the paper, but the title itself says infraspinatus. But on top of that, if you actually, look at the fine print, even patients who had isolated supraspinatus tears or actually having even a partial tear developed infraspinatus fatty infiltration. In fact, the table actually shows clearly, so that is one thing to actually look very carefully. Just not infraspinatus, probably supraspinatus in another papers also shows that, but infraspinatus in isolation, if you take, that's what actually the results are. But that is one point to ponder, just looking at the paper alone as a point. And what do you and other points of actually no return? That is another point which when we actually say point of no return, say grade 2 is what they have actually defined, but they've actually made a differentiation of 5 Guttalier to actually 3. And I think the point of no return is taken as grade 2, where you actually have 25%. But with the modern techniques, in fact, it has become more, that it is not a point of no return anymore. But the point of no return also signifies from the MRI study from others, which actually shows that the fatty infiltration does not recover even after you repair it after this particular stage. That's what actually, when the point of no return means, not actually repairability of the cuff. It is more when the point of no return, what they've mentioned and they've quoted in the reference as well, is the Gladstone paper, which actually says that the point of no return is when actually the fatty infiltration does not reverse. But I think, that's a pretty much a robust review of this particular paper. Thank you very much. And Dr. Karthik, Dr. Vineet, if you have anything to add on this, and Dr. Deepthi, sir, please go ahead, sir.
Yeah, Senthil, I'll just get to this. One thing very clearly on this paper is we cannot draw conclusions because it is not a study where you are looking at a serial follow-up of these patients. You are looking at patients who have already had a tear. They have come for some other surgery. You're looking at their imaging done before. So concluding that a traumatic one is going to not degenerate that fast or fatty change that fast is wrong. Okay. Only thing I found as a strength in that paper was the number of scans they looked at. But everything else we are trying to draw a conclusion. I don't agree with them at all. Because you need to have if you say a natural history of a rotator cuff tear or a natural history of a fatty change, you need to progressively look at it prospectively to get that idea of what's happening. You cannot look back on them and say that this is what it is. And that point about you saying that the supraspinatus tear also has a bit of infraspinatus. Now, rotator cuff, especially the external rotators, are single cuff tendon. It's a single tendon cuff. So once you get the problem with the cable anteriorly, there will be some amount of non-loading of the cable posteriorly too. And infraspinatus is part of that cable. The teres will be good. And actually teres will hypertrophy if you have a atrophic infraspinatus, because it's trying to compensate and trying to match up with the subscapularis.
Yes.
So that little change, I don't think we should read too much into it.
Sure.
From my point of view, I would
yeah.
conclude that just because it came from a unit which has done big thing is not a landmark paper. I'm sorry to say, but the methodology is not right to conclude what we have concluded in that.
Sure, sir. Thank you for the input, sir. So
Excellent.
I think
Can I add something?
Yes, please. Yeah.
Yeah, thank you very much, Deepthi, sir, for pointing out the problems with this paper. When we look at the natural history of rotator cuff tear, there are a couple of researchers who've done some pioneering work, like Ken Yamaguchi. Yamaguchi's papers, some papers are really good. He has followed up with the asymptomatic shoulders on patients who have come with symptoms on one side. And he has followed them up for 3 to 4 years. So there are only a couple of studies like that, but they have not commented on fatty infiltration. So when we look back when we look back, this is the only article which has come out long time back and is looking at fat infiltration. So they have asked the right question, but definitely they don't have the right way to answer this question because they don't have, they have just looked at one point and then they've tried to sort of call it. So what was so striking was when we see a patient with a cuff tear, we warn them that you can't wait for more than 5 to 6 months because by 6 months or by 9 months it might become irreparable. But Jill
No,
Walsh has
actually,
concluded.
can I just intrude there? Sorry. I was recently doing a paper on fatty infiltration and I was going through the literature, and I can't quote you the exact this thing literature, but they have very clearly shown that it takes around 3 months and 6 months it gets worse. And the papers which have looked at those things, looked at the
So
progression
that,
of the tear and looked at the progression of the fatty change also.
yeah, so I'm not sure if they have looked at the same patient at intervals, because if that's a paper, if there is a paper like it, that's definitely an important paper to look at. Otherwise, as Dr. Senthil pointed out, and as you point out, now we don't do much of CTs, we have access to MRIs, and we have the right questions to ask now. So this paper can be a starting point for us to look at a research question. So we can ask the right questions and we can formulate a study from the study, which we can take the flaws from the study and we can formulate a good study.
True, totally
So-
agree. Totally agree. So if you have a good study, bunch of MRIs or patients whom you can follow up and get an MRI, follow up MRI, and look at the fatty change, it will be good. But majority of the time in clinical practice, what happens is you see a patient with a fatty, tear, you have a fatty change. You can't go back and say that we'll not repair on you. We're going to wait and see what is going to happen with you.
Definitely
That
not.
is the difficulty in having prospective studies in this sort of situation.
Yeah, it's really difficult. That's the reason probably Jill Walsh himself had a retrospective sort of one-time study here.
Sure. I think
Okay,
the
so,
limitation, sorry, just to add final point on that. The limitation is actually for this much number. And also the point you made that you can't actually do a progressive study because, with this present, can you actually treat a traumatic tear and leave it and see how it progresses? It's going to be very difficult to carry out a control arm like that, sir. So maybe if there are newer papers in the future, journal.
No, ethically it can't be done. So,
yeah.
unless somebody refuses treatment, then it's a different thing. I think there was one paper where they refused and they looked at these. I think I'll look out that. I'll get that reference for you guys. I'll put it on the club.
yeah,
Thank you very much, sir. Karthik, I think we'll go for the next one. Yeah.
Senthil, one final takeaway from this article which you think which will be useful for everyone.
I definitely feel, the point is actually the fatty infiltration was brought to fore, much, and also because the importance of this is probably from the place it came from. And so it became, a very, quoted article as well, much. But actually, as Dr. Deepthi and also Dr. Karthik has pointed out, there are flaws. We need to critically appraise each paper, not just look at the author himself. That is one point. But the point for clinical practice, which we would actually take, is that fatty infiltration progresses, but it does progress significantly at one point when you actually see if it's a 4 tendon and in an aged group.
I have one question, sir. Can I ask?
Yes, go ahead, Giri.
Yeah, sir. This paper, like Deepthi and Nandan pointed out, has a lot of limitations for a young surgeon like me. Should we change the practice of seeing fatty atrophy in sagittal plane alone and consider axial plane as well? Are you going to change that? Does it make more sense?
No, for me it doesn't. For me, it doesn't make sense because when you look at a sagittal section, the axial section, there is no bony endpoint where you can compare it with. Whereas in a axial section, the sagittal sections, you will see your scapula as a nice bony point to give you a reference. Unless you're doing a volumetric assessment of the cuff or the cuff muscle using some software in a axial section, you're not going to get a good reproducibility of it. So that means inter-observer variation will be very high.
So
Giri,
the follow-up questions.
Giri, why don't
follow-up.
you take up this and compare the sagittal Y view tangent sign versus software assisted volumetric assessment of fatty infiltration in the axial view, and you can
Yes, sir. That has been already published in 2017, and like Sir pointed out in 2024 JSES May edition, there is a paper comparing the volumetric assessment of fatty atrophy in people. And just a follow-up question, sir. When you do only sagittal and you have a bony landmark, so whenever the tear is say 2.5 centimeter retracted, do you shift your viewing plane to 2.5 centimeter medial, or you stay with the same exact Y
No,
view?
definitely. Now more and more I'm using the body of the scapula rather than at your coracoid level or even a bit more medially. So we are going much more medial to look at the fatty change. So you have to be sure with your MRI technician and with your radiographers to tell them to take sections of it going right out to the end of the scapula.
That's an important point.
So
Most of the MRIs we see don't have cuts.
They don't have that cuts. So if you are doubtful, then get that cut repeated.
No, in future, I suggest like what Giri said. If you have recent papers which are actually trying to answer the unanswered questions, please quote them in your presentation so that we can go back and read those articles as well. Okay, if that is done and if you think it is useful, please share it.
I think as a follow-up, we can probably, add those papers in the subsequent journal clubs. So it will be useful as well, Karthik. I think we are running a little bit late.
Excellent
we'll
discussion.
Thank you. Excellent, Dr. Giri. Thank you.
Where are we going? We're going to Pratik now. So we'll go to one latest article and then we'll get back to another classic by Prakash. So I request.
I'll just introduce this thing.
Yes, go ahead, sir. Dr. Vineet, to just introduce the paper, please.
Okay. This article is actually quite new. It's published in the Arthroscopy Journal in May 2024. It's by Kevin D. Plancher, who's a well-known author and a well-known surgeon from New York. And it talks about a very common topic, arthroscopic labral reconstruction with inferior capsular shift, which has been done by all of us also. And he has followed a technique which has been described by Nebulang et al. Way back in 2011. But he's added rotator interval closure in some of the patients, and he's added plication sutures. So, and best part of the study is that it's got a very long follow-up. Average follow-up, although he's mentioned 5 years, around 12 years plus. So I invite Dr. Pratik Talwar, who's a second-year postgraduate in AIIMS Mangalagiri, to present this article. Then we'll have a critical appraisal of the article.
Good morning, sirs, ma'ams, my respected colleagues. Thank you, Deepthi sir, Karthik sir, and Shoulder and Elbow Society, and also OrthoTV for giving me this opportunity. I'll be presenting this article. Name of this article is Arthroscopic Labral Reconstruction with a Modified Inferior Capsular Shift Allows Return to Sports and Excellent Outcomes in Contact and Non-Contact Athletes with Anterior Shoulder Instability at a minimum of 5-year follow-up. The impact factor of the journal Arthroscopy Journal was 4.7. It is indexed in PubMed, and there were no conflicts of interest declared by the authors. It was a retrospective study. These are the authors, and they were affiliated to hospitals that in the USA. Now, collision sports and contact sports are known to be risk factors for recurrence post-shoulder instability procedures, and recurrent rates in athletes younger than 25 years has been seen as high as 70% and as low as 5%. Previously, the gold standard used to be the open Bankart repair, but nowadays it is seen that open Bankart versus arthroscopic repair recurrent rates are similar. As you can see, 3 to 22% versus 7 to 25% and 6.7% to 6%. Lower is a meta-analysis of open versus arthroscopic repair. And the mechanism of failure which we usually see after an arthroscopic Bankart repair are suture failure, anchor pullouts, insufficient number of anchors, failure of knotless suture anchors, and repeated traumatic injury to the shoulder. Now, also Latarjet or Bristow procedure is seen as a viable alternative even in athletes with minimal bone loss. And but the complications are high in this, such as screw breakage, recurrent dislocations, non-union osteolysis, malpositioning of graft, and most importantly, an alarmingly high rate of osteoarthritis ranging from 33 to 71%. This was, I did a literature review in which I found the systemic review in which it showed that in Latarjet, it is the recurrence rate was seen to be about 17.3 of 8.6% and complications of 7.3. Now, article discussion. It was a retrospective study that was done from 1999 to 2018 in the Plancher Orthopaedics and Sports Medicine Center. It included patients with single or multiple traumatic anterior shoulder dislocations, which were treated by arthroscopic labral reconstruction with a modified inferior capsular shift. The aim of the article was to compare return to sport, functional outcomes, recurrence of instability, and osteoarthritis between collision contact athletes and limited or non-contact athletes. And the hypothesis was that there will be no differences in both the groups. The materials and methods, the inclusion criteria were that it was an anterior inferior labral detachment from 12 o'clock to 6 o'clock position, glenoid bone loss less than 20%. They had participation in a collision or limited or non-contact sports, and they did a minimum 5-year follow-up. Patients who had a beaten score of more than 6, glenoid loss of more than equal to 20%, a torn biceps anchor, previous surgery on same side and less than 5-year follow-up were excluded. Now, on presentation, complete history examination was done preoperatively, and at the minimum 5-year follow-up, the history of dislocation events and level of sport activity were also documented and taken. They were classified into two groups: collision contact versus limited or non-contact sports. Four views were taken, X-rays, preoperatively and at the final follow-up: true AP, axillary, Bernard, and the Y view. The MRI was done without contrast, and the findings were confirmed on arthroscopy. The glenoid and humeral bone loss was determined by the sagittal oblique MRI. Bony lesions were determined by the best fit circle technique. The size of the glenoid was seen on CT, and Hill-Slacks lesions were classified into engaging or non-engaging type. Now, the surgical technique which followed, they after routine anesthesia, checking the ROM and shoulder examination, modified 3-portal technique was used, in which outside in technique was used. Arthroscopically, examination was done, and associated glenoid humeral defects, anterior labral lesions, and capsular tissue quality was checked. The labral tear was documented using the 12 o'clock to 6 o'clock face model. The anchors, regarding the anchor placement, the shaver or the hooded 3.5 mm burr was used to expose an area of bleeding cortical bone on the anterior aspect of glenoid. The anchors was placed at the 7 o'clock position in the right shoulder, 5 o'clock in the left shoulder. The orientation of angle was 45 degree relative to the rim and at least 3 mm inside the, but they avoided the glenoid cartilage surface. The suture passing instrument or shuttle was used to repair the inferior capsular and labrum from the inferior to the superior aspect. Bioabsorbable anchors were used to secure non-articular side with a modified sliding locking western simple knot and later reinforced with 3 half hitches also. Minimum 3 additional anchors based on the lesion size from inferior to superior were put till the 130 position right and 11 on left shoulder. Also, minimum of 2 bioabsorbable plication sutures were put in the anterior capsule in areas of redundancy. This was the final picture in which the journal authors shared after the shift. And also in patients who are having multiple dislocations, symptoms of laxity or subluxation during sleep, in those patients, rotator interval closure was also done. Now, a particular post-operative care and rehabilitation protocol was followed in these patients. Initial 1 to 4 weeks, immobilization was done with an abduction pillow for approximately 3.5 weeks, and the patient was told to remove it and let the arm hang for side approximately 5 minutes 3 times a day. Early mobilization was done from the POD to supine, active assisted forward flexion up to 90 and external rotation to 20. Suture were removed at 2 weeks. Splint was discontinued at 4 weeks, but they were advised to use the sling for sleeping and walking in public spaces. Progressive ROM exercises were started from 6 weeks, supine active assisted forward flexion up to 124th week, internal rotation 4th weeks, but they were told to avoid forced end range flexion. The ROMN strength goal which they had in mind around 6 to 10 week was within 10 to 15 degree of supine forward flexion and about 50% of external rotation to the non-operated limb the patient should achieve. And at 6 weeks, upright exercises with scapular stabilization, gentle strengthening at 8 weeks, isokinetic sport-specific activities in 11 to 12 weeks, and return to sports for non-contact, contact throwing athletes at 4, 5, and 9 months. And at the return of sports, they did the assessment using closed kinetic chain upper extremity stability test and shoulder strength assessment using a dynamometer. There was a 5-year follow-up with subjective functional questionnaires, a routine shoulder examination, and a repeat of plain radiographs. These were the patient-reported outcomes which they took, which was the 12-item Veterans Rand Hill Survey, Quick Dash, ACS score, Western Ontario score, Rowan, University of California, Los Angeles Shoulder Scale. For individual characteristics, up to an acceptable symptom rate, ACS score and Quick Dash was done, and also for each patient, satisfaction on a scale of 1 to 10 was noted. At the final follow-up, they did evaluation of the glenohumeral osteoarthritis using the Semmelself-Pareto radiological classification with no mild being inferior humeral or GH exostosis less than 3 mm, moderate slight GH irregularity with exostosis 3 to 7, and severe with narrowing sclerosis and exostosis more than 7 mm. This is how they did the statistical analysis and the results of the study. Initially, 92 patients were selected. In the end, 64 met the inclusion criteria, 5 patients had failure, and ultimately 54/59 patients were followed up. The collision category had 38 and limited contact category, non-contact had 26 patients. These were the individual sports and patients in each group. Now, these are the athlete demographics in which there was a significant difference as there were more younger patients in the collision or contact group. Also, the number being higher on the contact athlete group. The rest, there was significant difference. And also, these were the 5 athletes who required revision or had a failure, in which it was total 8%. 2 patients were of the collision category, 3 patients of non-contact category. 2 patients initially failed because they returned to sports activity against the surgeon advice, and rest 3 were traumatic or accidental. In post-operative outcome scores, as we can see, all the scores were had no significant differences, and patient satisfaction was 9 out of 10 in both the groups. The range of motion, external rotation per se at adduction and 90-degree abduction, preoperatively, postoperatively was significantly improved, but between the group there was not any significant difference. On comparison of GH osteoarthritis, as we can see, there was no arthrosis in 50% non-collision, 40% limited contact, mild and moderate arthritis in 15 2, and other side 9 and 2. And only 1 patient had severe arthrosis. Also, one more significant thing was that mild to moderate arthrosis patients were older or were at a mean of 52 years in comparison to patients who didn't have. Now, article discussion. In this study, it was seen that patient returned to same level of sports at a mean of 5 to 6 months. Overall recurrence rate was 8% in entire cohort, 5% in collision group. There was no difference in outcome scores, and moderate to severe OA were less than 10% at a mean of 12-year follow-up. Now, in various literature, it has been seen the return of sport is variable. John et al. Reported 81.8% return of sport at 35 months. Rossi et al. 73% return with 65% only of pre-injury level and 27 did not return. Although they said these patients didn't have any failure. And in this study, 100% of the patients returned to sport on their pre-injury levels. This was the Michael John study or John et al. Study in which we can see it was the 81.8%. And this was the Rossi study in which 88% patients returned to sports and 81% returned to same level of sports. Now, also an interesting thing in this study was that they had 70% and 90% variation. 70% return to sports was seen in contact or contact sport group, and 95% was seen in the non-contact or limited contact group. Also, they had a subgroup analysis comparing various sports return to activity or outcomes. Now, the surgery was done by a senior surgeon using the modified Bankar repair technique described by Nebulang et al. As you can see here. The speciality of this study was that they did anterior plication sutures, which supposedly reduced joint volume, improved stability, and improved proprioception. They reconstructed the labral capsular complex, which shortened the inferior pouch and decreased the laxity, restored stability. A rotator interval repair was done as an additional reinforcement in patients with complex history of shoulder dislocation. Other systemic reviews showed for arthroscopic Bankart surgery, usually low.
Pratik, just conclude so that we can have discussion because this is the entire study. So just go to the conclusion.
So conclusion of the study, according to author, was that they were successful in addressing anterior stability. Both co-groups returned with excellent functional outcomes. The functional outcomes were full shoulder ROM, low prevalence of OA at 5 years, and low failure rate in both groups. Critical appraisal of the study. The study question was relevant. The study did add something new, as that was a new surgical technique in which they were doing plication sutures and rotator cuff interval repairs also. The study design wasn't appropriate for the research question as it was a retrospective study and had younger patients in the contact group. Also, the number of patients were more in the contact group. The bias wasn't.
We'll address these questions further as we discuss. We'll start the discussion. So actually, this study has been done well. It's over more than 11 years done. So, and there was one drawback that they didn't clearly explain the technique which they've used, although they quoted the person who they've taken it from, Nebulang, and what only they told the number of anchors put, how they did the mattress suture, as Nebulang has told. They have not explained. And the other thing is that they mentioned plication sutures, how they did it, they have not. Rotator interval closure, how they did it, they have not mentioned. But overall, they've had, surprisingly, compared to other studies, very good results, almost 100% return to sports and a very low complication rate of only 8%. So, Dr. Pratik, so what is the bias in the study?
The bias in this study was that in the contact group and versus the limited contact group or non-contact group, more patients were in the contact group. Also, the demographics were unequal as more younger patients were in the contact group. And younger age group is another risk factor for recurrence in such cases. Also, if older patients are there, they were more associated with the glenohumeral osteoarthritis.
So the two groups were a little different when contact and non-contact. The younger patients in this thing. Yeah, so there was a little uneven distribution there. because it was a retrospective study. Okay, anything else?
Also, there was a low sample size in the study, and also they didn't do any subgroup analysis as they classified patients according to which sports they were playing. But as we know, with contact sports also, some sports predispose patients to more trauma. So that if they would have done, it would have been improved. And also only the last 5-year follow-up was considered rather than serially following up the patients, which could have given us more information how the outcome is.
Like you mentioned, though the study was quite long duration, the number of patients were quite low. And that is one drawback, I think, which has led to these results. But anyway, and arthrosis, they've said, what is the rate of arthrosis post this procedure compared to latter J?
Sir, it was around severe arthrosis was seen in one patient, and mild to moderate combined was seen up to, if we include mild and moderate, up to 50%. But in large, if we see the incidence, if we see advanced osteoarthritis is seen up to in 55 to 54% patients.
Okay. The rotator interval closure was done in almost 50% patient in almost both the groups. One was 50, other was on 44, right?
Yes, sir.
Okay. Now we'll open this thing. Any other questions, discussion regarding this paper?
What is the attrition rate? What is the attrition rate? How many were available for the last follow-up?
Sir, 54, 59, 5 failure, but they followed up to 54 patients, excluding the failure patients.
How many were lost to follow-up?
Lost to follow-up from 92 to 54. So approximately 92 to 54, sir.
So almost half the patients were lost to follow-up.
The 40%.
They were
out of the included patients.
They were included out of patient. Out of the operated patients, there was no attrition as said by the authors.
What is it? Sorry. So they had no loss to follow-up at all. Is that
They
what
did
saying?
mention, sir.
No. They would have mentioned what was the total number of inclusion. What was the number included in the
54.
Number included was 54, and what was the number available for the last follow-up?
54, sir.
So they didn't lose even a single patient.
Yes, sir.
Wow, that's great. I mean, that's really difficult.
That retrospective nature studies, sir, I think that's why.
Okay. So that is the thing.
So I think Pratik, hello, can you hear me?
Yes, sir.
Yeah. No, very well done. Excellent presentation.
Thank you, sir.
Okay, that's a very nicely presented paper. And one good thing about that paper is that the follow-up, minimum of 5-year follow-up in any soft tissue procedure for instability is a good follow-up period. And the average is around 11 years is excellent. I think the results is got from them without doing any remplissage. The two in sports person has been actually it's exemplary. If you look at the results we've got. But the technique, as was mentioned, is not very clear on it, so that we could probably take some cue on what the technique he had used.
Sir, I'll share the paper, sir. The Nebulan paper I'll share, sir.
Nebulan paper is a very old paper. Yeah, but it tells only the basic thing of what they done. What he did, he is not really told. And that's true.
Yes. So the only thing I found was a bit different was that in non-contact sports, the return to sport was higher, whereas in contact, it was not return to sport at the same level at which they were. Whether the contact person, sports people had some apprehension to go back to that level of sport is something we could think about.
In their group, almost everybody 100% went back, only 5 failures.
No, to the level at which they were. The last slide he put. 73% in contact and 90% in non-contact. to the level of sport they were previously playing.
Okay. But anyway, it's much higher than others. I mean, studies.
Oh, definitely. The arthritis point of view, I think there is definitely some degree of arthritis coming up in these instability patients, which you're seeing now lately. But it will probably also depend on the number of dislocations they have had pre-surgery. So that correlation, was it mentioned in the paper?
Sir, one case had, they said that one patient had severe GH arthritis at 12-year follow-up, but they attributed it to that at the time of presentation, intraoperatively, he had signs of mild to moderate osteoarthritis.
That patient was also quite old.
He probably would have had either more episodes of dislocation or a pre-existing cartilage pathology.
Yes, sir. Pre-existing, they said, sir, for that particular one severe patient which they have, severe category patient, sir.
Okay.
The rotator interval closure, they mentioned they did it for people who had sleep dislocations and those who had multiple dislocations. So it was almost 50%. Is that a good idea now if we want to take it forward? I mean, as a conclusion, I mean, whether we should do rotator interval closure, although they have not defined what they're going to do, whether it's SGHL to MGHL or MGHL to subscap, they've not mentioned anything.
I think a lot of now we have moved away to actually measuring laxity and looking at multiple laxity associated dyskinesias. Then we actually now decide upon whether you would actually do a rotator interval closure rather than actually an isolated sleep dislocation or based on the history alone. That's one point. And probably without actually having a remplissage in this particular paper, they have probably managed those dislocations which may have happened or subluxations, because it's a long follow-up. Most of these soft tissue repairs, we do find at 3 years, 4 years, beyond that period only we find the recurrence rates. Short follow-ups do not show the recurrence at all. So I think that one point is rotator interval closure. Can it be a substitute for remplissage is one thing, or a point to ponder maybe in the future, but at what expense? Will it actually reduce the rotations? Will it actually not reduce the rotations? Because, again, papers have shown that just isolated rotator interval closure in hyperlax patients, they tend to provide more stability.
The authors have noted that out of the 5 athletes who required revision surgery, the humeral defects were quite large. And in retrospect, the senior author, basically Kevin Blanchard, thinks that remplissage would have helped them. So the time study started, probably the group was not doing remplissage. So they were doing all that other than remplissage to tighten the capsule. But because it started long time back, right?
1999.
Most of the evidence for remplissage came around 2018.
Yes, sir. So that time remplissage was not popular when he started this. So I think he mentions it. He says that looking back, he says if he had done remplissage, he would have actually not had the failure. So I think it's a good paper.
Only 5, and out of those 5, 2 are very severe injuries. 2 they didn't return to sports. They went earlier. That is also he mentioned. So it is quite interesting.
Sure. Excellent. I think Karthik, should we move on to the next presentation?
Go ahead. Yeah.
Thank
you. There are no more questions in this. So what will be the take home here, sir? Vineet, sir?
I think, like they've said, inferior capsule shift is a good idea for recurrent shoulder dislocation, especially in contact athletes. Along with that, maybe plication sutures can be added. Rotator, now with the intervention, with remplissage being there, maybe you don't require it. But yeah, a good inferior capsular shift, as the authors have done, is a very good idea, even currently.
So you think we can take the results, to our practice straight away? So it's a good paper to actually agree to the results.
Yes.
Quality of the paper is good.
Yes, it is quite good, yeah.
So the doubters of soft tissue repair for Bankart can be, reassured. And no need to do lateral for everything.
It's a paper for Latage enemies. All the Latage bashers can rejoice on this paper, I think.
Even in collision athletes, soft tissue repair is, you can do
It is
it.
interesting part in that paper, actually. Yes.
Yes.
Thank you, Pratik, and thank you, Dr. Vineet. So we'll go to Prakash now. Dr. Vineet, you want to introduce this paper?
You're on mute, sir. Vineet, sir.
Dr. Vineet.
I'll unmute myself. Sorry. Dr. Prakash will be presenting this paper, and it is interesting paper, although it's published in the JBJS. It tells about the humeral insertion of the supraspinatus and infraspinatus. Although we always think that supraspinatus insertion is quite big, but here this paper will tell us what it actually is compared to the infraspinatus. And we will also know what is because of that, how we have to manage the patients. Okay, so I asked Prakash to go through the paper, then we'll discuss it.
Yeah. So, good evening, everyone. Thanks, SESI, for starting the journal club and giving me this opportunity. Happy to be here amongst a handful of purpose-driven colleagues. So this article is basically like a Japanese illustrated short story. It has got a great prelude. It will have some amount of dramatization and have an intriguing change in plot and a happily ever after conclusion. So you have to have your eyes and ears open because this has got some great visual treat. And we'll also answer President's question on how the infra is part of the supraspinatus tear. So here we go. So this paper is titled Humeral Insertion of Supraspinatus and Infraspinatus, a new anatomical finding regarding the footprint of the rotator cuff from Hirayuki Sugaya's school, done at the Unit of Clinical Anatomy at the Graduate School of Tokyo Medical and Dental University, published in JBJS in 2008 with an impact factor of 5.3. So I got introduced to this paper by a presentation by Ian Lowe in the year 2016. So when I was looking at this presentation, where anatomy of the rotator cuff tear, how to tell L's from the U's were talked about, and you see what is inside is intriguing. It says triangular shaped footprint of supraspinatus, 25% of it inserts into the lesser tuberosity. All those things are really intriguing. That's when I came across this paper, and today I have this opportunity. The abstract itself is eye-catching and jaw-dropping. So you're looking only at the highlighted areas of the background. So the atrophy of the infraspinatus muscle is frequently observed, even in patients with small to medium-sized rotator cuff tears. How can we explain this phenomena if only the supraspinatus is involved? And the clinical relevance, when it comes to the lowermost part of the abstract, it shows the rotator cuff tear has a substantial infraspinatus component. How did they draw this conclusion? And the clinical evidence is what we are going to see. The objective of this study was to reinvestigate the humeral insertion of the supra and infra. The background is to go against the traditional belief, focusing only on the supraspinatus as a primary tendon involved in rotator cuff tears. And the picture depicted shows the older insertion of the supraspinatus and infraspinatus on the highest part of the tuberosity and the mid part of the tuberosity. So they took 113 shoulders from 64 cadavers. They were fixed in formalin, 25 males and 39 females of an average age of 77.3. They got 99 shoulders for gross observation. After peeling off the supraspinatus and infraspinatus from the scapula towards the tuberosity to delineate its insertion. 15 of those shoulders were excluded because they had severe degeneration and torn cuff. They used a thoroughly detailed anatomical dissection. They removed the skin subcutaneous and delta completely. They resected the clavicle and the acromion. They also removed the part of coracohumeral ligament, and then they were exposed to the footprint, where they measured the supraspinatus and the infraspinatus. So going on to this picture, Picture A shows us the connective tissue cover of the supraspinatus and infraspinatus. Marked by the star is the insertion point of those two. And then this connective tissue that is present there, along with the coracohumeral ligament, is not allowing us to see the footprint properly. It shows us a confluent supraspinatus and infraspinatus. Whereas the picture B After removing the connective tissue of the CHL and the supportive soft tissue, now you see the supraspinatus is only a triangular impacted area. And you see the infraspinatus tendon coming all the way posterior and ending up anterior in actually a diagonal fashion from posterior to anterior, marked by the black arrows. Again here, when you carefully look at A, the infraspinatus is totally removed, supraspinatus is remaining intact. The insertion area of the infraspinatus at the greater tubercle is clearly observed in this picture, marked by the black line. And when you go to picture B, now they have removed the muscle off, they have removed the supraspinatus tendon off, leaving the footprint area and the capsule intact. Now you see that supraspinatus is only a small cuvette of attachment. Here again, another picture shows us the anterior portion of the tendon is attached to the lesser tuberosity also, the supraspinatus, while the posterior portion is attached to the most anterior portion of the greater tuberosity. If you can see picture A clearly. In picture B, the anterior tendinous portion inserts more widely into the lesser tuberosity. So this is how the supraspinatus occupies only a smaller area of the greater tubercle on the highest prominence, also bleeds over to the lesser tuberosity. This is their observation. So now coming at that axial view that we are talking about, the photograph A shows us the superior aspect of the right shoulder with the myotendinous unit. Now, when you carefully remove all the muscles off, leaving only the tendon, now you can see SSP-LT is the highest point where you have the lengthiest part of the tendon and thickest part of the tendon. Whereas when you come posterior and inferior, it becomes very small and it has become very thin there. So that is the characteristic feature of the tendon of the supraspinatus. Now you're seeing the photograph of the dorsal aspect of the right shoulder, showing the myotendinous unit. Now when you remove it off, now what we are able to see is a superior half of the supraspinatus is long and thick. Inferior half is short and thin. The infraspinatus occupies most of the greater tuberosity. That is what is the impact that this picture shows us. So now a beautifully illustrated picture on the left, mark A shows us the older thinking of how the supraspinatus and infraspinatus have been taught to us earlier, before 2008, before this paper was published. Now going on to picture B, you see that rose mark in supraspinatus is a right angle triangle that is formed. That is how much the supraspinatus is attached to the greater tuberosity. And you see a small rose spot on the posterior aspect of the lesser tuberosity. So it bleeds on to the lesser tuberosity as well. Whereas when you see the infraspinatus, it almost travels along the diagonal of the greater tuberosity, marking almost 50% on the highest prominence of the greater tuberosity and the middle and inferior part as well. So this has to be borne in mind. Also, when you look at this part of the this part of the picture, the older illustration will not include this because this area marks the capsular attachment of the shoulder, superior capsule. Again, now this is how they measured the width and length of the insertion point. So the width of the WLI shows the width of the lateral margin footprint of the infraspinatus. WMI is the width of the medial margin of the infraspinatus, whereas WIS shows us the lateral width of the supraspinatus and medial width of this supraspinatus. This is how it was measured. So the findings that they had was the footprint shape of the supraspinatus is triangular. Medial to lateral length is just 6.9 millimeter average. The antero-posterior width is around 1.5 centimeter, 12.6 millimeter average. So the insertional area, they concluded to have an anteromedial aspect of the superior facet of the greater tuberosity. What happened to the infraspinatus? The footprint shape, now we know, is trapezoidal. It is larger than that of the supraspinatus. The medial to lateral length is around 10 millimeter. The antero-posterior width is around 3 centimeters. So now the insertion area is much of the greater tuberosity, includes the anterolateral area of the superior facet wholly. So this is the average that they have marked. I've given you in the last picture. So going to the discussion of this thing, how did this fare with the other studies that were earmarked earlier? This study shows us the supraspinatus footprint is triangular and smaller. infraspinatus is trapezoidal and larger, whereas all the other older studies and even anatomy textbook will give us the supraspinatus inserts at the highest impression, infraspinatus into the middle impression as given by the previous picture. Again, dissection methodology. This group removed the coracohumeral ligament completely along with the soft tissue to expose the footprint of the supraspinatus and infraspinatus, whereas the other studies, including Clark and Harriman, showed it is difficult for them to dissect the tendons of separately within supra and infraspinatus. Tendon involvement, rotator cuff tears were previously thought to have a substantial involvement of supraspinatus, whereas now we know that we have to consider substantial infraspinatus component as well. So this was a study done earlier showing that 55 specimens were dissected and their contribution of infraspinatus was only 20%. Also, clinical studies were referred to, which showed supraspinatus involvement about 86 to 100%, whereas infra is only 14 to 48%. Muscle atrophy, infraspinatus muscle atrophy, according to this study, because of the wider footprint, should be considered in rotator cuff tears rather than suprascapular nerve damage alone. Because other studies which looked at the infraspinatus muscle atrophy showed us probably a suprascapular nerve damage leading on to a chronic cuff, but that did not show in most of their patients. Shoulder function, infraspinatus, according to this study, should contribute significantly to shoulder abduction, challenging the traditional viewpoints of supraspinatus only. Also, when we are about to perform surgery, the highlighted importance of recognizing the infraspinatus involvement in surgical repairs and delamination should be taken into account. In conclusion, the supraspinatus footprint is smaller according to this study, with significant portion occupied by infraspinatus. Clinical assessment and treatment of rotator cuff should consider substantial involvement of infraspinatus. These findings explain the frequent infraspinatus muscle atrophy. Accurate anatomical restoration, of course, is very important. If you understand this, you'll be able to do it better. The study strength is, of course, it is a larger sample size for cadaver studies. They have done detailed and precise measurements using PhD in mathematics, authors with a PhD, and they have got comprehensive anatomical analysis by perfect dissection. They've also brought out thoughtful insights, unbiased by their previous studies. Limitation, of course, lack of diverse demographic of the cadavers. They belong to only Japanese population. They could have included a multi-center study. Age and activity level could have provided a broader understanding of the anatomical variants. Picking up on their breadcrumbs, we can do a multicentric study on this with diverse samples and ethnicity. We can use standardized dissection protocol. Everybody in this study can do it. So we can also incorporate live imaging of the cadavers to translate this to live patients. And of course, if we can do a live longitudinal study, we can gain more inputs. Thank you.
Thank you, Prakash. Very well presented as usual. And I know you love anatomical studies because I've seen you dissecting in SRMC when you were there. Used to, even after the cadaveric workshop, you should be at it. So here, this very interesting study, like you said, 3 centimeter insertion of the infraspinatus. That is quite remarkable.
Yeah.
And can you just elaborate on what you are saying? The superior portion of the infraspinatus then will be participating in a little bit of abduction also along with the supraspinatus?
Because of the sheer size of it and then the confluence of these fibers onto the supraspinatus. That is what they make us believe. Although this is a cadaver study, we cannot establish the electromyographical impulse of the infraspinatus.
Only external rotation by the side.
Correct. But patient with pseudo paralysis who we tend to do a trapezius transfer, we most often will have a partial cuff that has been done or a little bit of a biceps augmentation. But most of the abduction will rely on the tendon transfer that we do, probably because this takes part in the abduction as well. Yeah.
Maybe that is why when we do remplissage also, since it's got such a broad insertion, it doesn't affect it much, I guess. That is also could be a point.
Yeah.
So I think
Yeah.
one point you clearly mentioned, the study probably gave us insight onto why we are developing fatty infiltration in infraspinatus. Maybe what we are actually seeing is actually infraspinatus, not the supraspinatus. Because in the MRI cuts, you are actually going through different cuts, and we actually consider insertion as, okay, this is supraspinatus, and we actually have an arbitrary variation because at the insertion point is almost impossible to define it unless you dissect it more proximally. Even here, compared to other studies, the strength here is that they were able to define it more clearly by removing the coracohumeral ligament and actually dissecting it much, because the other previous studies clearly wouldn't be, because there are the multipennate fibers and there is a lot of cross fibrillation. So you would not be able to define them clearly. That's the difficulty here. I think that's the biggest strength here. And so infraspinatus atrophy, what we may be seeing is what is actually not just the supraspinatus and infraspinatus because of the broad insertion point. So what we are seeing is not just supraspinatus.
There's a book called Rotator Cuff Problems Across All Ages. It clearly mentions image triangulation for assessing the fatty infiltration. So it asks us to look at the sagittal, axial, as well as coronal images. Coronal images, because we know where the tendon just ends, and then that's the mark for you to look further. So it's an interesting read.
No, in fact, we just had one study just presented by Dr. Giri. So in fact, a lot of patients in that study as well had shown that infraspinatus had fatty infiltration when you had isolated supraspinatus tears. So the difficulties obviously is to isolate the supraspinatus tear on, one cuts. That's probably the point I was trying to mention. Yes.
Yeah. So this paper really showed us the real anatomy of the cuff. That's what I feel.
Yeah.
And most of the time we think, especially with the radiologists giving us a report saying supraspinatus is torn, infraspinatus is intact, we invariably find that the patient has externalization weakness. So we should not be carried away with that report, because at least from this study, we know that the insertion of the supra is very, very small, and infra definitely is involved in most of the cuff tears. Isolated supra tear is a rare entity. It could, so mostly we see a supra along with a subscap, like an anterosuperior tear, or a supra with an infra, like a posterosuperior tear. So most of the times infra is involved, and it is important to reattach that infra or the posterior cuff onto the greater facet, or the bigger facet at the posterior facet of the GT, because that is what is going to give us the momentum or the balance, the equilibrium of the shoulder. So this paper was a landmark paper for me. I really this was good.
Yeah.
That's why we want to discuss this in the first journal club as well.
I had done dissection on 2 shoulders after seeing this paper, and I found the same findings.
So maybe it's time to actually do some cadaver studies here, because we have so much cadaver workshops going on, isn't it? So to actually look at our demographics and see, maybe the size of the tube, insertion as well would actually be very.
That's the thing. So we had Reddy come out so loudly and talk about 2 bundles of the ACL, and then the whole new thing from Poland coming and say, that's a Polish guy, right? Who came and said,
Smigelski, ribbon shaped. Yeah.
Ribbon shaped day. So if say Prakash and Senthil dissects the Indian shoulders and all the Japanese shoulders are not, that's not the truth. And if you come out with something different, it will be really interesting.
Why not? Yeah. Yes.
I have a point to make. Shashi Nandan from UK here. Thank you all for the fantastic work. Really great presentation. I've read this paper before, and trying to observe the U-shaped, L-shaped, on why it doesn't make sense for the delaminate tears to follow the pattern, routinely taught pattern of, supraspinatus is coming all the way, and you see the delamination from the posterior superior aspect all the way to the GT. And sometimes you see underlayer didn't make sense, but constantly used to challenge Mr. Discuss with the Leicester team as well. See, it doesn't make sense. And to some of my colleagues in Nottingham and other places. Rightly so, more and more surgeons are discussing or documenting as more of anterior superior cuff and posterior superior cuff, as opposed to classic supraspinatus, infraspinatus.
That's right.
Thank you.
Right, sir.
Yeah,
Thank
Prakash,
you.
thank you very much for that paper. I think I followed this paper from a long time. It's 2008. It's been, and we've been using this, the attachments of the footprints and everything as a teaching model in every meeting we go to also, because these are the images we normally use.
Yeah.
But one thing you notice when your clinical practice is this: when you actually look into most of your rotator cuffs closely, next time you go in, you see that there is a band of tissue which is continuous with the supraspinatus going
Correct.
anterior to the biceps.
Correct.
Now that anterior to the biceps, sometimes for the ease of access to the subscap, you sometimes cut that. That is
Yes.
something I stopped doing completely, because that is one of the part of your rotator cuff, the supraspinatus itself.
Yeah.
In people who have that, the footprint of the supraspinatus is much more smaller. So that's why you need to put your anchor a bit more towards the bicipital groove than when you're going towards when you have a broader one for the supraspinatus. So your anchor configuration also will change. And when you are repairing your subscap, having one suture probably going through this for your lateral row will help detension the supraspinatus superiorly also. And that is the mechanical repair part of it. But if you look at clinical scenarios, people put a lot of emphasis on supraspinatus. You see so many patients in the clinic which is supraspinatus tear, and they seem to have a normally functioning shoulder. That is because one, the cable mechanism, but second one, which is very important, like you've just shown, is that it is a good external rotation and also an abductor. And in my clinical practice, I don't do the Jobs test at all. In fact, I can detect a supraspinatus tear even with doing a regular arm adducted neutral position external rotation test, which is the infraspinatus test. With that test, you can even detect weakness in supraspinatus because it's all one sheet.
Yeah.
And they're all external rotators.
Yeah.
We have been taught that they're abductors, but actually they're external rotators and depressors.
Yeah.
The abduction mainly comes from your deltoid.
Delta.
So thank you very much for that. That is a very good paper. And we can't find flaws in that paper because it's an anatomical study. I love anatomical studies that way.
So, any more points to add?
No, I think that was excellent. From all the three speakers, Dr. Giri, Dr. Pratik, and also Dr. Prakash. So, closing comments from the president and also Karthik, please.
Thank you very much, Senthil, for organizing this and getting, mainly Karthik to get everything together. It was his idea. Although he said it was it was not mine. It was Karthik's idea. And he got it to work as well. And it is a very good thing to see journals and articles being discussed rather than giving somebody's opinion. And it is very critical, as Karthik mentioned, is to know how to read a paper. Many a times we look at an abstract, we take a conclusion, and we try to use that in a clinical practice, which is wrong. I think unless you have read the full paper and done a critical analysis of it, you cannot translate that into your clinical practice, is what we should learn. And this exercise will help us do that. Thank you very much for organizing.
Thank you, sir. And hopefully in the future, we'll have more articles and more discussions. And the recording is with OrthoTV. I thank Dr. Neeraj Bijlani and Dr. Ashok Shyam from OrthoTV for having collaborated with SESI, and they promised that they're going to collaborate with us for all our future events. So we are also planning monthly webinars with international faculty. So once we get the journal club going, we'll start with the webinars as well on one focused topic and one speaker, and we can utilize them, ask all the questions. And I thank all the participants, participants who joined through the Zoom link and also who are viewing on the YouTube. And those who are not able to join, the link will be shared tomorrow. And I think that's it. So thanks all the presenters, the moderators, and the mentors. So we'll again meet next month. Thank you very much.
So
Yes.
the recording will be shared, no? You were saying, Dr. Karthik?
Yeah. We'll share the YouTube link tomorrow.
And can we have the link of this recording on the SESI website as well, please?
Yes, sir. We'll do that, sir. Once the website is upgraded, we'll do that.
We should also do, I think, expert opinions on burning issues, sir, like when to take up pasta, should we operate or not, something like that,
See.
because just because it's a practice guidelines, we know it is still debatable, questionable, and all those things.
We will do
But
that.
at least, yeah.
No, I think if we focus our journal clubs on one particular topic,
Yes, sir.
after the journal club, you can
Yeah.
give out some guideline which we can
Yeah.
put on a
Practice
website and say
guidelines,
this is
yeah.
the guideline. So it
Correct.
will make it easier for us.
Correct, sir. Yeah.
And next time we will stick to 1 hour.
Yeah, you should. It
Not too
often
bad.
these discussions take long time. So
Yeah, correct, sir. I think but this was the first time, so I think, but we were all enthusiastic about it. But I think
whole
there's-
convenience about webinar is nobody stops us actually, unless we ourselves stop.
Stop,
we
yes.
can keep going, but I think we'll make it more concise next time.
Sure. Thank you. Excellent. Thank you very
Okay,
much.
sir.
Thank you.
Bye bye.
Thank you.
Thanks. Thank you. Thank you. Thank you.
Bye. Have a good night.
Bye.
Bye.
Sir, can I end the session?
Yes, please. Yes, please. Please go
Okay.
ahead. Thank you.